Good day, dear colleagues. I'm happy to see you today in our weekly webinar of Crystal Vision Eye Clinics by Professor Igor Aznauran. Today we will talk about complications in refractive surgeries and their management. And I think that it will be very interesting for all those adult ophthalmologists who are making a refractive surgery and use different techniques for that. And as we know, it is very important to find the best approach to each patient. And the art of surgery is maybe to have and uh, many different approaches to understand what is that complication and how we can do for the patients not to have this complication, and if we have, how to manage it. So today I will talk about these complications, and so I want to start about that all complications from refractive surgery, from laser correction, can be divided into intraoperative and postoperative. During intra surgery, we cannot understand that there can be such complications as deformations of flap, disruption of vacuum when we use LASIK, mistakes in choosing of ablation dose, violation of sepsis and antiseptics. And when we are talking about post-operative complications, it is for sure dry eye syndrome that we can see in many cases. Epitheliopathies, epithelial ingrowth, and regression of refractive effect, especially when we use such uh, techniques as PRK. So, and today we will talk about the complications that occur from time to time, even if you adhere to the technique and with full preparation for surgery. And first of all, let's start with the most widespread one. It is dry eye syndrome. As we know, it is the most common complication in the practice of refractive surgery after LASIK. So, first of all, for not having dry eye syndrome, we for sure need to understand what is the status of tears before we manage the surgery. And we need to understand that it is very important to do a shimmer test and also other tests for knowing real value of producing of tears. Because if it is low, please not do the surgery. You need to make their tears much more better there, so that there will be no dry syndrome before the surgery. It make much more. It gives us much more confidence that after the surgery, there will be less percentage of this complication. So after the surgery, and before, so the patient may not complain of dryness. However, in preparation for surgery, we for sure it is very important to take an anamnesis and identify different risk factors associated with dry eye syndrome. It is female gender, especially after 45, 50 years, meibomian gland dysfunction, usage of contact correction, Sjogren's syndrome, hypervitaminosis A, eating disorders, diabetes mellitus, and genetic disorders. Um, when we understand, first of all, in 2 3 weeks, this before the surgery, before LASIK and PRK and other laser corrections, in 2 3 weeks, the patient stops using contact correction. In 4 6 months, he stops wearing ortho K correction. So it means that this period, especially for ortho K correction, is can be very different. For example, we need to have three identical topograms in a patient who have ortho K correction before laser surgery. In some patients, it can be we can have it in 3 months. I have a patient whom I had seen for 1 year to have three dentic keratotopograms every month because of the very long using of ortho K correction before surgery. And so these patients switch to glasses and restore tear homeostasis. Also, if according to the Schirmer test and Norn test, we see it's very important not to forget about Norn test. We see a sharply reduced tear production. We carry out a specific local treatment of dry eye syndrome. So we can give a patient different drops for 2 weeks, for example, for making the tears normal before the surgery. And speaking of specific treatment, usage of cheap preparations, there is a huge variety of options as well as local treatment of circulatory laser stimulation of the lacrimal gland. And I want to say that in Crystal Vision Eye Clinic in Bahrain, we have these devices for restoration of tear production in patients with a dry eye syndrome. And if you have a patient who needs this treatment, or if you have some complications after a laser, you can refer these patients to us or write to me. I will be very happy to answer to the questions how we make this treatment, and so you will be able to understand how to inform your patients. So another important complication that we can have during after laser correction, it is appearance of hazes. Especially this complication occurs after PRK, and it is the main problem of the RS method. As a rule, there is a severity of opacities correlates with the dose of corrected ametropia. As much is the ametropia that we are going to correct, as bigger can be their hazes that we have. So histological hazes is formed in the subepithelial layers of the cornea, since the main effect of the laser is on the deepithelialized surface of the cornea, as we see here in the picture. And as a rule, we encounter this condition mainly after laser correction of patients with hypermetropia. I should say that in Crystal Vision Eye Clinic in Russia, we make refractive surgery, laser correction in kids, but we don't use it in myopic kids. We use it only in kids with hyperopia, with big astigmatisms, for making much better their situation in correcting their and treating the amblyopia. And as we have this much patients with kids with hyperopia, we are doing PRK in these kids, and we can see here in the picture their hazes that can be induced after their refractive surgery in patients with hyperopia, and we see that it is in the peripheric portion of the cornea because while making the refractive surgery in hyperopia, we are doing it in peripheric zone. So this is because the ablation profile in hyperopia involves exposure to the periphery, as we see, of the cornea, and is carried out for a long time, about 40-60 seconds. Is the treatment of hyperopia correction when we correct from 3 to 4 diopters of hyperopia. And this complication does not interfere with good visual acuity, but the presence of pronounced haze can affect on the post-ocular refraction as well as cause induced hyperopia. And the situation is worse in myopes, since here, on the contrary, because of the corneal flattening, the ablation zone is located directly in the optical zone. So, as a rule, during PLK in myopia and myopic astigmatisms, we don't encounter central cases, but there may be cases when the central opacities are formed after large ablations, especially after hyperopia. And as we know, there is a drug that mitomycin that with proven efficacy, and it is used very widely in refractive surgery, including in our clinic. And the drug is used as a short-term application on the corneal stroma immediately after ablation in the future, and so that the surgeon is able to make sure that there is no opacity even after repeated interventions. It can be useful even when there is no way to make a LASIK, for example, for patients with high hyperopia in adults, but you can use PRK and have very good results with mitomycin C. In our practice, when we perform PLK with the use of mitomycin C, as well as prolonged hormonal therapy after surgery, we don't encounter opacities in the optical zone. And as you can see on the slide of the corneas of different patients after the surgery, there was a fairly big ablation from 100 to 120 nanometers. Basically, sometimes we can observe thin hazes after laser correction for hyperopia. But even here, thanks to mitomycin C and therapy, so we use local, very long hormone therapy in PRK after the surgery, we have a quite good results. Another one unpleasant complication of the LASIK is ingrowth of epithelial ingrowth, and it is an agglomeration of epithelial cells in the interfere under the valve, and usually we can see it even in the next day after the surgery, when we see the patient next day in the slit lamp. And for example, in my practice, I have this complication only one during 8 years of practice as a refractive surgery. And the case success is two factors. Through cleaning of the surgical field after ablation and flushing of the interface after flap placement, and hormonal therapy in the postoperative period. It is very important to clean the zone that where ablation was made after the surgery to have very good results after that. And if this approach has been disrupted, the next day we will notice islands of the cells in the cornea, and this area disappear on their own at this stage on hormonal therapy with dexamethasone. But ingrowth epithelium can be quite aggressive, especially if the patient neglects drop therapy. In this case, we observe the further development and growth of more cells. So here it is not our pictures we had taken in the internet. The link you can see under their slide. You can see how during the OCT, even of the cornea, we can see how bigger is growing this epithelial ingrowth. And when we and if there is a large mass of cells in their interface after the valve is closed, aggressive growth may begin, which in turn will lead to this outcome. In this case, if it is necessary to eliminate this complication surgically, as it disrupts the refraction of the cornea and contributes to induced astigmatism, it is necessary to lift the flap and mechanically clean the surgical field. I would say that uh, from, from my practice, as I see, as quicker the complication is managed, as bigger is the percentage of their success after the surgery. So for me, if see this complication in the first day of the surgery and it is really big, and it takes uh, third part of the cornea, better to go to the surgery room to clean it and then give hormonal therapy to the patient so that there will be no complications after. Uh, so basically, all intrant postoperative complications are associated with the formed flap in LASIK, and it is can be displaced, deformed, and twisted. And as a rule, complications occur due to improper placement of the microkeratome and vacuum breakdown during the formation of the flap. To avoid vacuum breakdown, it is important to properly center the keratome and as well as to avoid any effort and force. So in our practice, we use Moria microkeratome, and I should say that it is one of the best microkeratomes for usage because it is very understandable how it works. Their eye is always under your vision there, and you can really control the work of their microkeratome. And there is no surprises when the flap is done. And the secret of proper surgery consists of using the entire range of vacuum rings, one of which is definitely suitable for an individual patient. And there are very steep corneas up to 46, 47 diopters of refraction, as well as quite flattened from 39, 40, which can cause intraoperative flap tears. And thanks to their schemes that have, for example, Moria microkeratome and any others using uh, uh, the parameters of the cornea, you can find the right ring and the right parameters of the ring that will be used in these patients for not having complications with the flap. Uh, but if a tear does occur, it is extremely important to mark the cornea before the creating of a flap. So for marking, we use special instruments that make this mark not symmetric. While not symmetric, because then if you have a tear flap, when you're managing and for understanding how to put it in the right way, you will be not able to put it not on the right side because uh, for matching these marks on the cornea and on the flap, you need to put it only in the right way of the cornea. So it will give you one more chance not to have these complications after the surgery. And using the marks prepared in time, you will be able to correctly straighten the detached flap and center it on the cornea. And uh, uh, the surgeon is able to determine the exact position of the flap as well as the front sides, since success depends on this. And also, flat tearing can occur after a perfectly performed surgery at home, but this depends only on the patient behavior, how careful he is with his eye. So it is very important to say to patients not to to be very careful with the eyes. And usually, for example, in our practice, we give special patches to patients even for the night. So they will patch their eyes and not to be able to stretch. In this picture, you see the um, non-symmetrical marking when you need to match uh, 3 points on the cornea that was teared and on the on the flap. And if, for example, you will put it not in the right on the back side, it will not match their position. The position of their marks will be not right. So thank you for your attention for listening this information. I will be glad to answer any questions if you have for uh, for for my talk. And I think that it will be great to share with each other their importance of right managing of complications and to be aware of them. Um, Also, I want to uh, invite you next week. We will have a webinar on tactics and peripheral retinal dystrophies. The speaker will be Dr. Victoria Balasanyan, head of the clinical department of the Crystal Vision Eye Clinics by Professor Igor Aznaurian. And it will be also at 8 a.m. And we will be very happy to see you there during the webinar. So thank you very much for uh, uh, meeting us here in the morning. I hope you will have a good day and see you next week at 8 a.m. Good day.